Welcome to AI for Good, the leading, action-oriented, global and inclusive United Nations platform on AI. Organized by the International Telecommunication Union, the United Nations Agency for Digital Technologies, in partnership with 50+ UN sister organizations and co-convened with Switzerland. The goal of AI for Good is to unlock AI's potential to serve humanity. In today's AI for Good event, we are counting on you to use the live video wall feature to ask questions and post comments to help create an engaging discussion. We encourage you to stay until the end to chat, connect, ask questions, and network with our distinguished facilitators and world-class AI experts in the neural network. It is now time to kick off the session and welcome our first speaker. The floor is yours.
Hello, good morning, and welcome to the ITU ILO AI and Work series. My name is Janine Berg. I'm Senior Economist at the Research Department of the ILO. Today's session is on Are Doctors More Effective When They Use AI? Results from an experiment in Indonesia, Kenya, and the Netherlands. We will be discussing the findings of a randomized control study undertaken in the 3 countries that sought to evaluate whether medical doctors' diagnostic performance was improved by the use of a large language model. With us today are some of the project team members from across the 3 countries and the ILO to discuss the findings as well as their perceptions about use and applicability. The project is a collaboration between medical researchers and doctors as well as economists and labor researchers. Funding for this research was provided by INRIA, the French National Research Institute on AI, on behalf of the Global Partnership on AI. The project team consists of 25 researchers. Here with us today are some of the team members from the different participating institutions. We have Marie-Christine Fregin and Nick Rounding from Maastricht University's Research Center for Education and the Labor Market in the Netherlands. We have R.D. Findiandi and Lufti. Hello, can everybody hear me? Yes, okay, wonderful. So the project team consists of 25 researchers. Here with us today are some team members from the different participating institutions. Marie-Christine Fregin and Nick Rounding from Maastricht University's Research Center for Education and the Labor Market in the Netherlands. R.D. Findiartini and Lutfi Sariful Arif of the Medical Faculty from Universitas Indonesia, Jakarta. Sadabanu Rashid Sukwala and Soraya Manjeev from Aga Khan University Hospital in Nairobi, Kenya. And from the ILO, we have myself and my colleague, Pawel Gmyrek. I want to begin by turning the floor to Pawel, who will start this discussion with a little background on ILO's estimates of the exposure of generative AI on different professions, including doctors. Pawel, you have the floor.
Hi, everyone. Let me start by maybe saying a few words from the ILO side about the workforce and how doctors belong to it. So 3.6 billion people wake up every day and go to do things that we later consider that they are as employment. Among those people, about some 70 million people work in the health sector globally, which makes some 2.1% of the total employment. And from that, 20% of these professions are doctors, which corresponds to more or less 12 to 13 million people around the world. So it's a very small share of the total global employment, below 0.5%, but it's a really important one, since, for example, access to doctors is one of the typical ways we can measure inequality. And that varies greatly. We measure access to doctors by the number of doctors per 10,000 people, and that can vary from 65 or more in some of the high-income countries to below 10, significantly even below 10 in some of the low-income economies. Now, when it comes to thinking how doctors fit in the overall professional structure that we deal with the ILO, let me share my screen and show you how we think about occupations. So this maze is basically the way we structure occupations when we try to link statistics to them and count them. And there are 10 professional groups. If you follow the professional paths, you will find here health professionals who split into 5 main categories, and that these later break down into even greater detail, and we find doctors as generalists and specialists. But that's not the end of the story. That's sort of just the global classification. When we actually unpack it and we look at the national classifications, you can see that this tree breaks down, in the case of Poland, into 80 different professions that are related to doctors. And these professions, when we look at their detailed tasks, have over 1,200 tasks assigned to them in the context only of Poland. And that can also vary greatly across countries. So there's a huge variety in terms of what doctors do. What you can see here as traffic lights is what we have been using together with these scores in the brackets to try to understand to what extent technologies like AI today could automate partially some of the tasks that different professions do, including doctors. And let me close by saying that this research that we are engaged in is not something that we're thinking about in terms of trying to automate doctors away, but rather understanding the impact on this huge variety of tasks that they have to perform, and see how potentially some of these technologies could liberate doctors to have more time to spend with patients, or to spend more time on more of these complex tasks where technologies are not very helpful for the moment. And that is important because there is a great shortage of doctors around the world that is estimated by 2030 only at 11 million people. So with that, let me hand over to the next presenters so we can discuss this exciting research.
Thanks, Pawel. Now I'd like to turn to Marie-Christine, one of the project leaders and a researcher at ROA in Maastricht, who will present in greater details the aim of the project, the methodology, as well as introduce some of the main findings.
Thank you very much, Janine. While I share screen, maybe we can invite everyone to share their screen so that actually people out there see at least the 6 out of the 25 team members that we have available to us today. And let me zoom in. 1 second. Sorry for that. All right. Does not share in presenters mode, but let's ignore that. So thank you very much for having us, Janine. We're talking about AI like everyone else does. And many also talk about AI in healthcare, from diagnosis to chatbots in hospitals. The conversation on this topic is really global. But when it comes to the evidence on AI in healthcare, the evidence really is not global. To our knowledge, ours is the first study to really add a cross-national perspective in a very systematic way, examining the impact of Gen AI on doctors' clinical reasoning in very different health system contexts. We designed a randomized control trial, a scientific experiment that allows us to understand whether and how AI can help doctors think and decide better. Because when it comes to healthcare, we really do have a global challenge. We really have a global challenge in the sense that millions of people die each year, not because of a lack of access to care, that also is a challenge, but also because the quality of care they receive is too low. In many regions, poor quality care even causes more avoidable death than the lack of access itself. And within the quality of care, it's the clinical reasoning that's the central determinant, because the clinical reasoning is what connects medical knowledge to the right diagnosis and the right treatment. So And then if people experience symptoms, physicians are very often the first ones to provide a diagnosis. So in that sense, improving the quality of physicians' clinical reasoning is a challenge that we should take up, and really enhancing the clinical reasoning process. Now there is AI, but whether AI can generally really enhance clinical reasoning, that's not known yet. And we still know little about that whole thing. Clinical reasoning, this we know, is shaped by training, local context, and best practices. But that also then means it requires global research. To shed light on AI's potential, we conducted our RCT in 3 very different healthcare settings. In the Netherlands as a high-income setting, Indonesia as an upper middle income setting, and Kenya as a lower income setting. And our goal was also to see whether AI could help equalize quality of care around the world or not. So I need to switch. It's not ideal how I have to switch around here. I'm sorry for that. I don't know. So, but let me go to the aims of our study. We had several aims besides looking into the quality of care. It's really also about examining whether AI can augment doctors. It is about examining or to testing whether AI assistance is effective in very different healthcare settings. And there is to see whether there are performance gaps in doctors' clinical reasoning between the countries, but also whether AI can help equalize global care inequalities. Fourth, it is about understanding when and how AI can help. So this is really about the mechanisms in terms of usage patterns, physician experience, context, and stuff. So that fifth, policymakers and educators can make use of our study findings when they're designing responsible adoption strategies. In accordance with these aims, we made some central decisions. The first one is that we decided to look into primary care settings, so not all the very different doctors that Pawel also showed, but only these, and our team will provide more information on that. But we also decided to choose a publicly available general LLM, ChatGPT 4.0. We did so because it is widely used. It's a general purpose tool that still performs very strongly on standardized exams, and it's feasible to use it the same model in all the countries. So this makes it ideal to study AI augmentation, not replacement, which is really what we want to do. And we published on our findings already, and you can look into medRxiv, where you find one paper that we published on the impact of LLM assistant on physician decision-making and a multi-country randomized control trial. And you will indeed see there are many people involved in this that you can, of course, also contact to discuss our research. Let me go into the study design, because we don't only want to talk about the why, but also the how of this study. What we did is we conducted a randomized control trial, a parallel group RCT in Indonesia and Kenya and the Netherlands, with all in all 249 doctors. 50% of them completed the experiment with the AI assistant. And each of the doctors completed 5 standardized clinical vignettes. Now, what's a vignette in that context? A vignette is a scientific methodology that can be used to train, or that's frequently used to train clinical reasoning, to assess it, but then also increasingly to test it in state-of-the-art studies that are examining LLM use in healthcare. It is what's a patient vignette? It's not more than a written description of a clinical case. So it combines symptoms, it combines previous findings, and it combines the medical history of a patient. And it allows researchers like us to evaluate how doctors perform in a more or less standardized way. And we're not talking about very complex cases. We're more talking about the common symptoms of a flu or of lower back pain. We did provide a random half of the physicians with access to ChatGPT-4. The other random half completed the study unadded. So they completed the experiment unadded. And the outcomes that we looked at were diagnostic reasoning and management accuracy on the basis of best practices. All right, how did we do that in practice? We created an online environment, a survey into which we included ChatGPT-4 window. Clinical reasoning has different steps. In between, there's usually differential diagnosis. And here you see an excerpt from our survey. The first vignette, 62-year-old woman reports with persistent lower back pain. Then we integrated the chatbot window for the treatment group. You see the history, and then you see the physician's answer that was provided to us for statistical analysis. And that gives us a number of beautiful analysis and graphs. I only want to show you this one. It actually provides a lot of information. And my colleague will talk you through the details in a second. For now, let me just focus on the overall results. So what you see here is basically 3 figures in one for Indonesia, for Kenya, and the Netherlands. You do see squares, triangles, or dots in these panels. These represent the individual scores of the doctors that participated in the experiment, and higher scores are located in the upper parts of the panel. Lower scores are located in the lower parts. And you also see this dark little diamond. If you see my mouse moving around, that's the ChatGPT 4.0 benchmark. We had ChatGPT do the test as well. And for each country, you then see 2 panels, one for the group without access and the other one for the group, what we would call in economics, the treatment group, the group with access to ChatGPT 4. And our main finding, as you can see, is this. For all the countries, we do find that the group of doctors that had access to the LLM performed better than the group without. Looking at the distribution, we also see that in all countries, the best performing agents, for example, here in Indonesia, the best performing agents without LLM outperformed a number of doctors that had access to the LLM. So let me summarize quickly. Let me summarize because Nick will go into the details more. We do see performance gains everywhere, quite substantial performance gains, which leads us to thinking that AI has quite a substantial impact, can have quite a substantial impact on doctors' performance in clinical reasoning. We also do see an indication of an equalizer effect because the gains were largest where the baseline was the lowest. So that is an indication for that. At the same time, AI clearly does not have the same effect for all doctors. And there are distributional effects. Among the really interesting findings that we have, we can see that high AI users outperform low AI users. So it's really not only about the availability, it's really about how people use it. At the same time, we do see that some without AI outperformed AI users, which makes it clear that AI is also not a guarantee for a high performance. And this brought us to the last empirical part of our study, which was qualitative research that the partners conducted in Indonesia and Kenya, conducting interviews with doctors to also look into their perspective. Most of them, or all of them, actually see AI as a very helpful tool, but they do raise benefits and they do see concerns, which will be shared by my team member in a second. And they also say that the output that, of course, you receive from an AI largely depend on the input. So it depends also on sound prompting skills. And they did reflect, in short, as a main finding, that AI should exist, but should not replace professional reasoning, because in the end, it's really the doctor who stays responsible. Let me close this first part of our session with a key takeaway, which is we do find evidence that AI can augment doctors' reasoning. There's actually quite a big improvement that could come from LLM use. And in our study, we also provide first indications that it could help reduce inequalities in global care. But for sure, more research is needed. And for sure, the central role in this is not played by the AI, but the human plays the central role in this. Because the key question is, how do we maximize the benefits that come with AI in healthcare and balance it against the pitfalls that are also really serious? So our main takeaway is this: it does augment, it can help equalize, but when it comes on to the decision on how to use it, it's really the human experts themselves that are in the driver's seat. Thank you.
Thank you so much, Marie-Christine. And with that really helpful overview, we're now going to dive into a little bit more detail about the findings, but also the experiences, particularly from the perspective of Indonesia and Kenya. So let me turn now to Nick Rounding, who's a colleague of Marie-Christine's at ROA, who's been instrumental in moving this work forward. Nick, can you walk us through a little bit more, some of the more fine details about the results and what they're really telling us?
Yes, sure. So what we did is we really wanted to see how AI could augment doctors' decision making, as Marie-Christine says. And we did this by running the randomized control trials. And this is really important because we got doctors in a room together in a controlled environment. We were able to remove external distractions, for example, and we asked them to complete our vignettes online. And this allows us to isolate the effect of GPT-4 on their performance on these tests. So the differences between the groups we can say is caused by the access to ChatGPT. So that's really important that we were able to do this and isolate those effects. Let me talk you through these graphs just a little bit to try and understand and interpret the results, having taken that into consideration. Along the bottom axis, you can see it goes from 0 to 1. And 0 is the lowest scoring person within that group, and 1 is the highest scoring person in that group. So as we move along the bottom axis, you get to higher scoring people. And then on the vertical axis, we just plot their average physician vignette score. And this is the score. We asked the physicians, the doctors, to complete 4 vignettes each. On the conditions, and this is their average score across those vignettes. So it kind of provides a holistic view of their performance on our tests. And you've got also, so each point is the physician's average score. Then you've got these boxes that are kind of overlaid on this. And those boxes represent what we call the interquartile range. So at the bottom of the little box is the 25th% of the score distribution, and at the top is the 75th. So this graph kind of give you some indication of how similarly doctors acted when they had access to GPT-4 and when they didn't. And we can see that there's differences across countries. So obviously we can see that the right-hand side, the points are generally higher than on the left-hand side, so the without access versus the with access group. And that shows that GPT-4 did work and improved their performance on these tests. But there is differences across countries in this, which my colleague will get into later. And we can also see that, as Marie mentioned, there's significant overlap between the two groups. So whilst the group with AI access may perform better and generally may have performed more similarly, there are still people who didn't have access who outperformed almost all the with access groups. And there are people who have access to GPT-4 who didn't perform as well. What could be causing this? Well, one of the hypotheses that we think about this overlap is if we think about, you can be provided with access to a tool, but that doesn't mean that you necessarily use it. And we find it interesting that there could be a difference in usage. So we decided to track the usage of GPT-4 across our vignettes. And our vignettes are split into different steps of the diagnostic process. So we're able to say, in this step, so when you're asking the patient questions, did you use GPT-4 or not? And we decided to split the groups into two groups. So we took the treatment group, so the people who had access to ChatGPT, and we split them amongst how often they used it in the experiment. And we did this in each country because we found some difference in usage across countries. So for example, in Indonesia, 50%, they used it in 50% of the steps on average, whilst in Kenya, they used it, for example, in 81%, and then the Netherlands in the middle. So if you can move to the next slide, please. This will show you some of the results for that, which I think is quite interesting, because you can see when you split it into a low and high usage group, at the median, you can see that the group generally in higher usage outscores the group in lower usage. So this gives us kind of a really important indication and finding that it's not just providing access that results in better scores. It's also more use. So if we think about this from a policy perspective, we really need to think about and understand how people use GPT-4 or any LLM, and how they interpret that knowledge, which I think the qualitative results that we'll come to maybe provide some insights into that. But also that we can't just provide access to these tools and say use them without thinking about the usage patterns that we do find and what that could mean in cross-country settings, but also within country and how different people use it. So to summarize, we find an effect of the access to a large language model, but that this may be moderated by usage of that language model and how individuals interpret and use the knowledge that they gain.
Wonderful. Thank you, Nick. And of course, the country experience is so important because it really does differ depending on the country. So let me turn now to the project team in Indonesia. And with us, we have Ardi Findiartini, who's a clinician and educator at the Indonesian Medical Education and Research Institute at Universitas Indonesia in Jakarta. So Ardi, I have a few questions for you. My first one is, why use patient vignettes? What criteria did you use to pick the diseases that you focused on? And why carry out the study on general practitioners?
Yeah, thank you very much. I think I would like to address the first question first. Why we use vignettes? Because we would like to trigger the doctor's clinical decision-making or clinical reasoning process through the clinical vignettes that picturing actually the real cases. We would like to see how the doctors then use their knowledge as well as the AI. And also it means that it also describes doctors' decisions, beliefs, and attitudes in their clinical decision-making. And we find that it is the most closely related to the real practice. Hence, it's enhanced also the validity of the study, because the clinical vignettes use is very important to trigger the clinical reasoning. So the way that we ensure the quality of the clinical vignettes, the writing, the design, and structures and methods, the teams from the 3 countries discussed that very well. And why is it that we pick at the general practitioner level? Because we find that the use of AI now, we want to aim for the general practice first because of the use of AI in the potential use of AI in general practice will be if we can do it well and appropriately, will be of great advantage for our colleagues in general practice. And in picking up the cases of picking up the cases from we see the most common cases in 3 countries, the cardiovascular cases, the respiratory cases, musculoskeletal fatigue, and so on. And so we pick for 5 cases, 4 standardized cases, and 1 quite more complex case to really to trigger the clinical reasoning. Because in practice and also theoretically, if a doctor is exposed with more complex cases, they will have a different system of thinking to support their decisions. And it will probably influence the way that they use any information, including the suggestions from AI. So that's even though that we have already decided the use of the cases, we still try to calibrate the cases, particularly in trying to, even though it's similar cases, we carefully prepared the cases by considering the specific context from the 3 countries. For example, the availability of certain diagnostic measures or laboratory examinations, or the availability of certain drugs, and so on and so forth. So I hope this addressed your questions, Janine.
Yes, thank you so much. Let me turn now to your colleague, Lutfi Saiful-Arif, who's also a clinician and researcher at Universitas Indonesia. So Lutfi, during the experiment, you gave physicians access to ChatGPT to tasks from their daily practice. Could you tell us how the doctors felt about using this AI tool during the experiment?
Okay, thank you, Janine, for the question. We do believe that our qualitative finding in Indonesia provide insight to your question. After the experiment, we invited 15 respondents from Indonesian experimental group to the interview. We wanted to know their experience when they used the AI assistant to solve clinical vignette. So most of our respondents didn't see AI as something that would take over their role. They treated the AI just like a second opinion, something they could compare their thought with. If the case was familiar, they usually trusted their own intuition first, then used the AI just to make sure that they weren't missing anything. For unfamiliar cases, some of them use the AI just to get the ideas or fill in the gaps before then they use their judgment to solve the cases. Also, a few say that AI actually made the thinking process feel lighter. Instead of holding every possible diagnosis in their head, like you know that one symptom may lead to several possible differential diagnoses, they could look at what AI suggested and decide whether it made sense or not. That took some pressure off from their head, especially when the time was limited, the doctor was tired, or the case was unclear. They also feel a bit reassured when AI suggestions align with their own reasoning. But even when our respondents used the AI assistants, they didn't just accept the answers. They also filtered what AI said through their own medical knowledge. Some mentioned that when AI gave an answer that sounded off or weird, they just adjust their reasoning and did a double check. They were basically using their own thinking, and AI respond to check each other. They were still very aware that the doctor were the one who are responsible for the final decision. Because of this, we believe that doctors see AI didn't replace their judgment, but just help them to confirm it. Still, not everything about AI make them comfortable. Please move to the next slide. A few were worried that if the doctor relied on AI too much, it could slowly weaken the doctor's own thinking skill, like critical thinking or analytical judgment. There was also concern about autonomy. Some of them said clearly that AI should never make the final decision. They don't want people who follow whatever the system tells them. Also, everyone agreed that AI should stay in the background, not interfere with the doctor-patient interaction. Our respondents said when they use AI in front of the patient, it could distract the patient and make the patient feel uncomfortable. Some also believe that if the doctor focused too much on the AI, the patient would think the doctor was arrogant, and just because they ignored what patient said. That's why our respondent preferred to use AI after the consultation session was ended to keep the doctor-patient interaction work smoothly. Our respondent also believed that empathy, active listening, and clear communication become something that only humans can properly do. Another concern that our respondent mentioned was trust. They didn't feel comfortable with AI suggestions that lacked clear sources. They mentioned about AI hallucination, and they wanted responses that were clearly based on scientific sources, such as journal or guidelines. Without that, they think the patient safety could be at a huge risk. Lastly, there were also practical issues. Not everyone knows how to give a good prompts. Most of them just type whatever that came into their mind with no structure, no example, just a simple comment. And this action limited how useful the AI was, just because AI only gave them the general or fake answer. In the end, the overall impression was pretty consistent. The doctors were open to AI, but only as a supporting tools. They want AI to help them think, spot things they might overlook, and reduce some mental burden, but they don't want AI making decisions for them. They still see themselves as the experts and the final decision maker. For them, the best role for AI in a clinical setting is as a partner only. I think that's all for me. Thank you.
Oh, thank you so much, Ludwig. It's really interesting to get that feedback about how their experience with it. I think with any AI moving forward, that's really critical to know that and to incorporate those findings. So let me turn now to Kenya. We have the two members from the project team there, and let me start with Soraya Manji, who is an expert in internal medicine at Aga Khan University in Nairobi. So Soraya, looking across the three countries, and particularly in Kenya, what differences do you see in how AI was used and perceived?
Thank you for your question. So as much as there were similarities, as you can tell, where diagnostic reasoning was improved with the use of the LLM access, there were some differences. And I know Nick and my colleagues Nick and Mary Christine did go through some of these with the graphs that you show. But just to go into a little more detail, basically doctors in Kenya, we'll start with Kenya, had the highest improvement with LLM access, which is about 18% higher than those who did not have the access. And Kenya also had the strongest uptake of LLM compared to the other countries. And there seemed to be a more homogeneous performance, which basically means that the scores were very similar. And that just goes to show that this could possibly reduce the variation in physician performance and actually help in like standardization of practices, and ultimately, hopefully, improve quality of care that is provided. As far as Indonesia was concerned, there was an improvement. It was about 10.7% with the LLM access. However, there was a higher variation in the scores for those who use the LLM access. And this therefore basically says that the impact of the LLM depends not only on the access but also on how actively one is using it and also how effectively one is using it. So perhaps, the education part on how to use the LLMs can actually help in standardization and providing quality of care. You can go to the next slide. As far as the Netherlands was concerned, there was about 7.2% improvement with the LLM access, which was the least of the three countries. We also noted that they had cautious uptake in the use of LLM, as you saw in the graphs provided. And what was very interesting is that the lowest scores were in the group with the LLM access in the Netherlands. And some of the possible explanations to this are the fact that there was low use of the AI, but also there could be automation biases, which is basically over reliability on the use of the LLM without critical reasoning. And that's some of the differences that we saw. The important thing to note, and the key point that comes out of this, is that as much as there's similarities, the impact of AI is context dependent. So we must keep that in mind as we're looking at implementing some of these things in the future. This was more on the quantitative studies that we did. We can go to the next slide. Kenya and Indonesia both did qualitative studies as well. And interestingly, there were very similar findings in both institutions. So the benefits that we saw, as my colleague Lutfi actually talked about, is that there's a broadening in the differential diagnosis that people noted, and also aiding recall of rare conditions. So if you look at some of the things they said, it gave me more differentials than I had in mind. I had maybe 2, but the AI suggested 5 or 6, and most of them were actually clinically reasonable. And of course, there's some pitfalls, which again, my colleague mentioned, over-reliance on the AI. For example, they said it made me lazy. At some point, I stopped thinking and just followed the prompts. That was a bit worrying. But also the other thing that came out strongly was that, the fact that they would be seen using AI in a clinical setting, the doctors felt that this could undermine patient trust and perceived physician competence. And one thing that came out in the Kenyan qualitative study, which probably was not present in the Indonesian study, was that there was lack of local relevance. That was one of the themes that came out, whereby some of the diagnosis and some of the investigations that the AI was suggesting were not relevant to the local context. So, for example, one of the comments was, it kept recommending tests we don't even have. It needs Kenyan calibration. That just tells us some of the things that can be done to kind of improve the platforms in a way that it can be context dependent. Thank you. That's all from me.
Thank you, Soraya. That's really fascinating also about the test recommendations in Kenya. So let me turn now to your colleague, Saribanu Mohammed Rashid Sekwala, who is a consulting physician and endocrinologist, also at Aga Khan University. So Saribanu, what did you find most surprising or interesting about the study results? And what, as a medical educator, do you think doctors, educators, and health systems in general should learn from this research?
Thank you very much. I think overall the whole study was just an exciting experience. It was amazing to work with colleagues from across the globe, all the way from Netherlands, from Indonesia. And to tell you the truth, it was not only the outcomes. You know, when you're doing research, you would expect to see, okay, the outcomes are exciting. But I think the whole process, because AI is relatively new for all of us, especially in our part of the world, the whole experience was actually quite exciting. And I must say, I want to thank the whole team. We learned quite a lot in the process. So as we go towards implementation of these findings of the study, we also need to understand that it was a learning experience for us as well as educators. So some of the things that I think that came out, and I'm more or less on the tail end to summarize what all my colleagues have already mentioned. And the basic thing that really came out as far as medical education is concerned, well, we were not specifically looking at the impact of AI on improving medical education, because we were looking more at the impact on clinical reasoning of clinicians. But most of our participants, as you've already seen, were in training in their residency, which is where we place like them as being in the primary care settings while they are still in training, not yet become clinicians. What we said is, what we can say is the first thing that we talk about when we look at education, what are the spaces in which we could use AI? And I think even from previous studies, what we do understand is that there is a role of AI in teaching, basically. Just if you look at medical education, just the aspect of its use in patient simulations, providing vignettes for clinicians or the clinicians in training to be able to understand how to use them in a kind of a risk-free space before even they encounter real patients, has already been looked at, and the benefits are being seen, even including in evaluation methods using AI-generated evaluation tools, which help in giving individualized evaluations for each of the candidates or for each of the trainees that we look at. Now, from our study specifically, then how can we bring all this together into the education space, first of all? And so the first thing that we have understood from both the quantitative and the qualitative studies is, yes, we can make use of AI to augment decision-making, clinical decision-making. But in the education space, what I can say is that we realized that there were differences or variations between the countries. As you can see, like from what both Nick presented and also what my colleague Lutfi and Soraya presented, is that there's a variability not only on the access of the AI, but also on how you use the AI. So one thing that we could use when we are training our trainees within the undergraduate or the postgraduate learning spaces is how to use the AI, how to generate the prompts, at what point to use it, and how most effectively to use it. Because when we saw the clinicians who used it effectively and the usage was higher, the outcomes was less variability. So if you're looking at equalizing or rather providing equity amongst the regions, then that's one thing I think that we could adopt its use in clinical space as far as the like how to give prompts as well, how to utilize it, at what point to utilize it in decision making. So what we want to train, what we're trying to say is, we want to have it in, we want to integrate it, like some of our facilities already have policies on how to integrate it into clinician training use, but not at the point of replacement, at the point of augmentation. Like if you have a vignette, give a simulated case, for example, or a real patient scenario to a candidate, and then if you're looking at how you'd integrate AIs, the clinician is supposed to still go through the overall history taking of that patient, and then probably have an access to the AI to see what additional questions they might have missed with a particular presentation, which they could not have probably thought of. And that augments their thought capacity and even their capacity to integrate multiple options. Same goes with the examination aspect with the diagnostic tools available. Now, having said that, another thing that I think Soraya brought out is also the responsible use of AI. So we need to see how we can use it then responsibly in medical education. Another thing is the balance between, as per what I've said, critical judgment with the AI support rather than replacement. Now, a very important thing that came out from our qualitative study is the aspect of contextualizing, in the sense that saying that, you see, if we have a clinician sitting in a facility which is in a remote setup, let's say, for example, in Kenya or in Indonesia for that matter, where you've got limited access to certain facilities, especially when it comes to diagnostics and treatment facilities, then that AI that we have, if the clinician is accessing information through the AI to help in diagnostics, what came out is there's a lot of diagnoses that come in, and a lot of them are not available in our facilities or in our regions with resource limitations. And so in that case, then the models that are being used across the different spaces globally should probably have some input from, like on the back end as the large language model, to have input from the contextualized aspect of that particular local context, meaning that input from probably the specialists within that country or region. So that's something that probably could be evaluated further. Now, when we look at its use in health systems now, in the spaces of healthcare in the different parts of the world, what we realize, like especially in our part or our region, is that we have limited resources, not only with diagnostics and management, but also with healthcare provision, which means that if we look at Kenya, for example, I can say within the larger cities, we have got our specialists, they are mostly populated within the larger cities, and we have very limited access to specialist care in the peripheries or in the remote regions of the country. And in that case, the most commonly treated the patients who visit those facilities are most likely to be treated by a primary care specialist, a primary care doctor who may not necessarily be a specialist and who may not always have access to specialized care. So if we contextualize it and we have the large language model at the back end contextualized to the local setup, and we educate at the same time our trainees on how to prompt or at what stage to use the AI and on what corrective policies we have in place, then what can happen is actually, at least in the initial stages when the patient comes to them, they could get the use, or rather adopt the use of the AI to help them come up with the diagnosis immediately and institute at least immediate diagnostic and treatment measures within the context of their space, and then refer the patients rather than mismanaging the patient. So that's a space in which we feel like it could come handy, especially if we eventually try to standardize it across the healthcare system, education and delivery. So yeah, that's what I would say. But the most important thing at the end of it all is to say that yes, it can improve quality and equity in healthcare if it is responsibly adopted and if we have policies to guide its use and educate clinicians on policies for safe use of AI. Thank you.
Thank you so much. That was really comprehensive. And so definitely the themes of contextualizing to the local context and also training doctors on how to use AI properly. With that in mind, and assuming all that was put in place, are there any other limitations and concerns that all of you, particularly the doctors on the panel, see as possible risks? I was struck, for example, by the comment that someone posted about how they were worried that was going to make them lazy. I don't know if any of you would like to maybe reflect on some of the concerns you might have had with your experience.
I think there are actually evidence showing that what we call as AI de-skilling for medical doctors. So that phenomenon has been happening. So in regards to that, I think the doctors needs to I would like to use the term of the human-centered use of AI. So it means that if we use AI, we use AI as our partner. We use AI as the instrument to help us, including in helping doctors in developing their decisions, but not taking over the responsibility to take care of patients. And I think Pawel has already also highlighted the needs of if doctors can be helped by AI in appropriate way. So hopefully the time that has been used for that kind of process can be then readdressed to taking care of patients more carefully, empathizing with the patients and their families. But then I think the challenge of it is also to assure that doctors not get lazy and use AI appropriately, as in we also need to be aware not just get the things done or get the decisions appropriately, but also in the importance of having those kind of thinking processes throughout our professional careers, because doing that way, it means that we assure that we stay professional, because we cannot just rely on the AI, but we need to be able to rely on ourselves. But yes, the AI descaling has been happening, I must say. So we need to be very careful with that.
Thank you. Let me have another question to you. Do you feel then that maybe one way to get around all these issues would be to integrate AI more into medical school training? So how do you think that should be done in a way that would be effective? Does anybody want to take that question?
I may try to answer it, and I'd like for help from others as well. We have an undergraduate training program at the Aga Khan University. So I think we cannot deny the fact that AI is here with us and it is to stay. So what the university has done currently is to have policies surrounding AI. What we have seen utility beyond just diagnostic reasoning is heavily with our clinicians is, like I said, one of the aspects where we are strongly kind of using it even in our postgraduate training is the use of patient simulations, like to help us to create vignettes, to create cases of patients and assist our, the clinicians or the clinicians in training in both undergraduate and postgraduate to work around that. And then at the same time, in as much as it is the what do you call it, during the training aspect, the use of AI, we're also guiding them on how to, guiding the educators on how to use AI-generated, AI methods to teach and also to evaluate the trainees. So the use has come in, but of course, where the concern is the use of AI in, for example, assignments, when they're submitting their assignments or when they are doing their research projects. And then the whole project has been generated by AI. So to come around that again now, in as much as we have policies, unfortunately, we don't yet have extremely strong tools to detect. But I mean, now we are better off than what we were maybe just when AI came 1 or 2 years ago. And I think that keeps on evolving. But now the point is to work around it and to come up with methods of teaching and of learning which are beyond just the typical didactic, assignment giving and all that, going more towards understanding and conceptual kind of based thinking. So yes, I think there is definitely, it's prudent to start integrating it into training, both undergraduate and postgraduate, but keeping all these concerns in mind.
Okay, so we have 2 questions from the audience. One is from Dedi Linga asking, was the LLM that was used in this study medical grade, or was it just general LLM such as ChatGPT or Gemini or Claude? Maybe Nick, maybe you want to answer that.
Yeah, sure. Yeah, so it wasn't specifically trained on medical documentation. And the reason we chose for that approach is when we started this over a year and a half ago, basically all the literature and studies were showing that GPT-4o, which was the top model, kind of frontier model at that time, was outperforming all the medically trained ones. So there was, for example, MedPalm by Google, or a couple of Google AIs, and then GPT-4o would outperform them on licensing exams and other kind of simulated tests. So we decided to just provide access to GPT-4o and see how that would go instead of using a specifically medically trained one.
Okay, great. And maybe let me just ask you a question. What did you find were, what surprised you the most about these results? When you got the results from the experiment, what were you most surprised by?
I think I was most surprised by the variance in usage across countries. I think that was, so, I mean, I kind of, based upon the literature with AI augmentation, I wasn't overly surprised that it helped improve physicians, but I think there was the differences in the way that it was used across contexts, and these kind of different contextual differences that are being teased out and shown. And I think it really highlights the value of doing this this international research and kind of doing the same research in different settings, so you can see different usage patterns, and this kind of local contextuality is very interesting. And also still that, I mean, even if you give people AI access, some people, so we have the ChatGPT, GPT-4o also perform the experiments, and we saw that some people perform better than GPT-4o. Some people without access perform better than those with access. So it's not kind of one of these things where we can switch it on and go AI, yay, everything's better all the time. It's very dependent, and this is why integrating it into the education systems and understanding how different people use it in different settings, I think, is a really important and valuable insight from the research.
Wonderful. And let me now turn to the team in Indonesia and Kenya. Was there something that surprised you the most about the results? Is this what you had expected when you signed up to be part of this study? I don't know, maybe Lutfi, if you want to jump in, or somebody else. No.
I think in terms of exploring, I see this study as, even though that is with the randomized control trial, when we try to control most things in the study, including the vignettes, including the doctors groups allocated randomly into groups with access to the LLM and the one without access. I must say that I personally see this as more of explorations. Of course, if we just rely on the results, Indonesia's results, I think, is rather lower compared to Netherlands and Kenya. And we think about, is it due to the case? Is it due to, because we don't want to, like, this is our doctor's ability. We don't want to address the findings that way. But at the same time, we would like to see more of the advantage of the study in how then our doctors should be well prepared in interacting with the cases. If of course, in terms of being exposed with the real life cases compared to the vignettes, we try our best to make it as close as to the real cases. Still, there are some adaptations, of course, in rather than addressing or solving the problems in terms in the forms of clinical vignettes in the laboratory setting compared to the real case setting. So I think it's a very critical explorations, and give us deep reflections around how then we can support our doctors better, our residents, and even our medical students to use AI in their practice. And to add on what Saira has said around the impact on the training, I guess, in addition to some of negative impacts of AI in our assessment, in our learning process, I think it's unavoidable. We need to tackle that. And of course, in regards to the use of AI for clinical reasoning and clinical decision making, it's important to see first the use of AI in our healthcare system. Hence, we can, we can use that as information to update how we prepare better our medical students and and our residents. Thank you.
Yes, thank you so much. Yeah, I think it seems really clear that it's certainly a promising first results. There is definitely a promising role for AI in the medical profession, but a lot more needs to be understood, and we have to move slowly and carefully, and definitely involve all of the doctors, the medical professions, all healthcare professionals really in this process. So that really is key to all of this. So we're at the top of the hour now. I just wanted to let everybody know that we will be publishing the results of this study, both the quantitative and the qualitative research, as an ILO working paper, which will be coming out next year, also incorporating some of the background exposure scores that we had done here at the ILO. So that will be published as a working paper and a policy brief. So please look out for that next spring. And then also just to let you know that on October 30th, we will have another AI for Good, ILO Live session, this time looking at women in STEM education that will be featuring Alexis Antoniadis of Georgetown University in Qatar and Hannah Liebman of the ILO. So thank you so much, everybody, for listening. And I hope you found it as enjoyable as I did. Have a good day.